September is Prostate Cancer Awareness Month. We're doing our part today by kicking off the program with a close look at what is really the most common cancer in men today. Prostate cancer. 1 in 9 of us likely to have this disease. 175,000 new cases per year, the most common cancer in men in the Western world. But there is some good news about all of that. We should always take prostate cancer seriously, but that doesn't always mean it deserves aggressive treatment. We're going to get into all of that today as we've learned more about prostate cancer over the years. There's a gentleman in the studio who knows more about it than certainly any of us, I think, listening probably do, and that is Dr. Mark Dabagia. He treats patients with Prostate Cancer Center of Northeast Indiana Urology on the DuPont Hospital campus. Welcome to HealthCall.
Thank you for having me.
What do you think is the most important thing men need to know about prostate cancer treatment today?
Most important thing is that it's easily diagnosed and in most cases easily managed, especially if caught early enough, that the treatment has improved dramatically over the last 25 years. And if you are at a high-risk population, to ensure that you get screened.
I think that's good advice. We'll talk about screening and other things in just a moment. Let's start with some anatomy. So we have all guys have got one, but I think not a lot of guys are really all that aware. The prostate is a walnut-sized gland right in front of your rectum, and then through that passes the urethra, which is the tube that allows urine to pass out of your body. Most of the problems start with an enlargement of that gland. Tell me more about that.
So the prostate, your analysis of the anatomy is excellent. The prostate is determined by a guy's genetics. So if your dad had a big prostate, you're going to have a big prostate. If your dad had a small prostate, you're going to have a small prostate. If your dad had voiding symptoms, you're going to have voiding symptoms. The prostate's main purpose in life, sole purpose in life, is to ensure that the semen can survive within the vaginal tract of the female. So without a prostate, we can't procreate.
Okay. So BPH, this benign prostate hyperplasia. Tell me more about this.
So BPH is a condition in which the prostate, it doesn't even have to be enlarged. It can be normal size or it can be large. And usually what happens is the glandular growth of the prostate impedes upon that urethra that is coursing through the gland. Usually it exhibits itself with a slower urinary stream, sometimes urgency, frequency. Guys may get up a little bit more at night. Sometimes they may hold on to a smaller volume of urine or a larger volume of urine. And once they get to a point where it affects their quality of life, then we start getting into appropriate treatment, whether it's medical or surgical, and there are a myriad of surgical managements for BPH.
So BPH and its link to prostate cancer. If I have BPH, does that automatically increase my risk of cancer? No. As a matter of fact, it's extremely variable. Most guys that we see with prostate cancer have very little voiding, have very little voiding dysfunction. So I don't have those symptoms that I'm going to look for. So what are the symptoms I need to watch for?
Again, most guys who are diagnosed with prostate cancer don't have symptoms. Usually if you do, unfortunately, it's at the later stages. If you have obstructive symptoms, that's usually not something we want to hear in somebody with a new prostate cancer diagnosis. So again, it comes down to finding that high-risk screening population or people that are at risk and identifying them and moving forward. Obviously, guys who come into my office and they have BPH complaints, certainly if they're in a certain age or if they have any findings on physical exam, we'll do PSAs on them. But
PSA is
prostate-specific antigen,
and that measures a protein that is put out by the prostate, but we don't know why, right? I mean, it can be related to cancer or not.
Correct. Yeah. So PSA elevation in itself does not mean that you have prostate cancer. As a matter of fact, only about 30% of the guys that I biopsy with PSA elevations in normal exams will have prostate cancer. In our practice, it's actually probably closer to 30 to 35%. And I think that's just because we, and I say not Northeast Indiana Urology, but we as urologists, I think we do a better job of trying to identify who is a candidate and who is not.
So if I have a high PSA, that's the first trigger that you're going to start looking for something. The digital rectal exam that we should be having every year, you're not checking whether or not the gland is enlarged. What are you checking for in that regard?
Well, when I do an exam, I want to find out if there's any abnormality along the peripheral zone of the prostate, because that's what we can feel, ultimately. We can't feel the entirety of the gland. We can feel about 70% of the gland, and that's usually the peripheral zone. So I'm looking for a bump, a lump, any type of tethering or induration within the gland, something that would trigger, along with the PSA, the possibility of moving forward with further diagnostics.
Okay, so I've got a high PSA, I've got a normal, you don't find anything in the DRE, but I've got a really high PSA that's tracking high. What do you do about that? What's the next step?
So the first thing that we do is I want to know what the patient's age is. I want to know what his family history is. I want to know if he has any voiding issues. I want to know if he's at a high-risk population. I want to know if it's his only PSA. Is this your only data point? Because very rarely will I biopsy somebody on one data point. The only time I'll do that is if there's something obvious on the exam, or if it's an extremely high, PSA in a high-risk population. The first thing that we do is counsel the patient. So it's normal for a guy with an enlarged gland to have a higher PSA. It's also normal as you age to elevate your PSA. Those are all normal findings and well-defined by the American Urologic Association. So the important thing is counseling. So if you want to let's divide them into index patients. So your first index patient is the guy who is, 40 years old to 54 years old. Very rarely, do we recommend annual screening and exams for those patients. As a matter of fact, the AUA recommends no screening for somebody less than 40 years of age. Even the guys that are at the most high risk of or the most high risk, guys with family histories of prostate cancer, guys, African Americans, there is no guideline to recommend a screening for somebody under 40 years of age. We don't recommend annual screening for somebody who's 40 to 54. Now, once you get 55 to 69, at that point, we discuss risks, benefits of biopsying diagnosis of prostate cancer, and certainly those patients that are at high-risk populations, African Americans, guys with first-degree family history of prostate cancer. Those guys should be counseled appropriately on screening and getting their PSAs done.
Okay. So we talked about prostate cancer as if it's one disease, but just as skin cancer comes in different forms, squamous, basal, and then the most dangerous melanoma, prostate cancer is not just one type of tumor, right?
Yeah, terrific point. Prostate cancer now, and actually we've divided the categories of prostate cancer into 5 groups. Group 1 are patients who have Gleason scores of 3 + 3 = 6.
What's a Gleason score?
Gleason score is a nuclear grade of the cell, of the prostate cancer itself. Whereas the lowest number that you can use in a Gleason score is a 1, and a Gleason score of 1, those cells are most like normal cancer cells. The most abnormal appearing cell is given a Gleason grading of 5, and those are the cells that look the least like a normal prostate cancer cell. So when we look at a Gleason score, we take the 2 most common sources of those cells and we add those scores together to get the final score. So when we talk about Group 1 disease, we're talking about 3 + 3 disease = 6. We're talking about Group 2 disease, where 3 + 4 is equal to 7. Group 3 disease would be the most common cells now, a Gleason Group 4 + 3 = 7. Group 4 disease would be 4 + 4, and any Group 5 disease is put in a Group 5. And the reason we group those is because the Group 1s do not act like the Group 5s. The Group 2s do not act like the Group 3s, and the Group 4s certainly don't act like the Group 3s. But the 4s and 5s are the ones that are in part the highest risk disease.
And if prostate cancer has touched someone in your family, the phones are open. You can ring us up and talk to Dr. Mark Dabagia of Northeast Indiana Urology. We were talking this half hour about prostate cancer. We've kind of covered a lot of the background and some of the nuts and bolts that you need to understand about this disease. Let me run through some real myths and facts with you here, Mark. Saw palmetto and other supplements are going to help manage BPH. True, false?
False. There are no controlled studies that says that saw palmetto or any other supplement is any better than placebo.
Diet and exercise are key to preventing prostate cancer.
Diet and exercise are good for your heart. If it's good for your heart, it's good for your prostate.
Cancer of any type in your family increases your risk of prostate cancer.
It can. Certainly a first-degree relative with a history of prostate cancer, first-degree relative being defined as your brother or your father, certainly can increase your risk, and a maternal risk of genetic-based tumors such as ovarian and breast cancer can as well increase your risk.
Testosterone therapy for low T increases your risk of prostate cancer.
Controversial, but the current AUA statement goes against that as a myth.
So that is a myth.
Yep.
Okay, that's good to hear. Because, as I think the audience knows, I've talked about it before, I'm a believer in testosterone therapy. I think it changes the way you feel. And what do you see in your patients? How do they respond? Well, let's jump into that for a second here. One of the key steps when you are found to have prostate cancer in the aggressive forms is you're likely to have medications that knock out your testosterone, right?
Depending upon the treatment that you choose, that's correct. So what you're referring to is androgen deprivation. And in guys who, especially the guys who choose radiation as their primary treatment, part of that treatment paradigm is the addition of an androgen deprivation medication that will decrease your testosterone and castrate levels. I think what you're referring to at times is, what do we do with guys who take testosterone and then ultimately they're definitively treated for their prostate cancer? I face that all the time in guys that I operate on who, were on, testosterone replacement therapy. They'll ask me, hey, when can I start my testosterone? And I will tell them unequivocally that it is controversial, but the current AUA guideline statement is that I can use that as long as their PSA is undetectable and they don't have any high-risk characteristics associated with their cancer specimen. I'll put them back on their testosterone almost immediately.
So one of your specialties is robotic surgery. When am I going to have surgery versus radiation?
So that's a personal choice and it's a fairly extensive counseling session with each individual patient. But if I'm going to be general about it, the younger you are and the more aggressive the cancer is, the more likely you are to have surgery. So one of the first things that you have to assess when someone's diagnosed with prostate cancer is, what's their life expectancy? And the majority of guys that are healthy, highly functioning, that have life expectancies in many cases, 25 to 30 years, they'll choose surgery. The guys that ultimately will choose radiation are guys who, for whatever reason, are averse to surgical intervention, or guys that may have more comorbidities and may not do as well with surgery, or guys that even have higher risk disease, but maybe their disease specifics or maybe their survival isn't, in that 20 to 30 year life range.
Am I going to preserve my sexual function with surgery today? Because that was a huge issue when this started. So
surgery's gotten eminently better over the last 25 years. With the advent of the operating robot, we're able to see more, we're able to identify more anatomy, there's less blood loss, you're more careful with the tissues, you've got better dexterity with surgical instruments inside the patient. So all of that translates into better postoperative outcomes. Now, there's a caveat there. Patients that are less than 60 years old are going to do better than the guy who's 68, 69 years of age. And it's just all in the counseling. I could belabor the point and go over all of my statistics, but it's suffice to say, the younger you are, the better that you're going to do. And the older you are, you have to understand that your risks of incontinence, your risk of erectile dysfunction long term are going to be worse.
Makes sense. I get that. What's the role of genomic testing? So if I'm diagnosed and you have my biopsy, you've pulled tissue out of the tumor, what do you do with that to tell me how I might best be treated?
So I use the genetic testing in my practice. I think my partners do basically the same. Are the patients who are diagnosed with group 1 disease who are candidates for watchful waiting.
Well, we haven't talked about that, so describe watchful waiting.
So watchful waiting is for a gentleman who has been diagnosed with by definition, a low-volume, low-risk prostate cancer that we, quite frankly, don't have any evidence is going to ultimately cost them their lives as far as disease-specific survival is concerned. So, what we'll take is that patient who has no more than 3 cores that are positive for Gleason 6 disease, no 1 core that is greater than 30 to 50% positive, and send those specimens or part of those specimens away for genetic testing. It's called an Oncotype DX test. That test will give me a risk on that patient of being either very low risk, intermediate risk, or high risk disease. Now, here's the important point. 30% of guys with 3 + 3 = 6 disease are actually guys who have 3 + 4 disease. So the Oncotype test gives us that next data point, which allows us to counsel the patient and kind of move forward, either with confidence or with a subject eye moving forward as PSA changes, it doesn't change, or exams change moving forward.
You know what? Time has just flown by here. We have about a minute left. What point do you want to make? What do you want to leave people with?
I want to tell guys that if you're at risk, make sure that you have the appropriate conversation with your physician, whether it's your urologist or your primary care doctor, and get screened. The highest risk screening populations are guys with first-degree relatives with prostate cancer, certainly African Americans, and have that discussion with your physician, and understand that the treatments have changed so much. Quality of life has improved dramatically, and comparing prostate cancer treatments today to prostate cancer treatments 25 years ago is tantamount to comparing the box TV that you used to have on your floor to the big flat screen plasma thing that you have on your wall right now.
If I have the diagnosis of prostate cancer, what questions do I ask to help me choose the provider who's going to take care of me?
First of all, you want to do a personal assessment. How good's your heart? How good are your lungs? Next, the discussion you want to have with your physician is, what kind of risk category does this put me in? Am I going to be better managed from a surgical perspective, from a watchful waiting perspective, from a radiation perspective? If I choose radiation, will I need androgen deprivation? That's important to guys as far as their quality of life is moving forward. You want to know what your physician's risks or your physician's numbers are with incontinence and erectile dysfunction. You want to know what your physician's experience level is. You want to know what the track record of a given practice is. So, those are all important questions to ask moving forward.
How soon do you think it's going to be before we can treat prostate cancer like a chronic disease, like high blood pressure, like diabetes, and just handle it that well?
We're not there yet. There are certain manipulations that we can do that will add 9 to 15 months, per manipulation. I'm hoping that, by the time we hit 2040, 2050, who knows, maybe we will throw prostate cancer into the same bucket as we put diabetes and hypertension. We're not there yet, but certainly we're leaps and bounds ahead of where we were 25 years ago.
That's all real good news about prostate cancer, the most common cancer for men in the Western world, and one that I hope doesn't strike your family. If it does, you can reach out to Dr. Mark Dabagia. He is in practice at the Prostate Cancer Center of the Northeast Indiana Urology Group. He sees patients at offices on DuPont Hospital campus, at a clinic on West Jefferson, and also in Van Wert, Ohio. And you can find them online at NEIurology.com.